Hi everyone. It's a pleasure to introduce Dr. Mariam Shati. Dr. Mariam, she has a Bachelor of Medicine and Surgery in Kuwait University, Fellow of the Faculty Radiologist Royal College of Surgeons in Ireland. She's Senior Specialist Radiologist and Head of Breast Imaging and Intervention in Mubarak El Kabir Hospital, member of Kuwait National Mammogram Screening Program, has 16 years experience in diagnostic breast imaging and intervention, passionate speaker, eminent breast radiologist.
Thank you. First, I would like to thank Dr. Mustafa and Almoosa for gathering all these experts because breast cancer is one of my passionate areas, and it's always a pleasure to meet all of you. Contrast-enhanced mammo is a game changer. The only way to know the pathology of the lesion is to have a link between anatomy and physiology. And this bridge is by the contrast-enhanced mammo. I have no disclaimers, and my objectives are really simple, just to see the indication and what's the difference between the contrast mammo and the MRI. The need for the contrast mammo raised because the pre-existing technology has some limitations. So the mammogram can give me only anatomy. And we know the more density, the lesser the sensitivity of mammogram. And the MRI, very highly costly, lengthy, torture procedure for some patients. A lot of patients can't tolerate to go through the whole procedure, and gadolinium is contraindicated in renal failure. A lot of them are claustrophobic, so it's not an easy procedure. Some people think because there's no compression, it's easy. I just want to do an MRI, but they don't realize how difficult it is to go through a breast MRI. Contrast-enhanced mammo, just use your standard equipment, the one you already use, with just an upgrade with a copper filter and a software, and the IV iodinated contrast, the one that used the CT, and you're ready to go. The beauty about contrast-enhanced mammo, it's not only they give you the abnormality, but it also can give you the extent of the disease. And one of the limitations that was mentioned yesterday, the radiation. Okay, everybody is afraid about radiation. We know that the radiation depends on the breast thickness and your machine settings and all these things. But in average, when you do a full field digital mammo, one breast, two views usually gives 3 to 3.5 milligray, and any additional view you do, it's 1.2 milligray. Okay, and we all know in diagnostic, we never satisfied with only 4 views. We always have extra views. When we do contrast-enhanced mammo, it's only 4 to 5 milligray per view, which is way below the limit, the FDA limit, which is 6 milligray per breast. Okay, so yes, there is minimal increase in the radiation dose, but to a very extensive diagnostic gain. And this is just to give you an idea. The first one is mammo plus only one extra view, and the contrast-enhanced mammo can answer so many questions without any extra views. And the last one is DBT. This is just a comparison in the radiation dose. So actually, we're not harming our patients. It was approved in 2011, and it was an amazing, new, promising modality with an extensive research, but there's different practice all over the world. Okay, the benefit of having a contrast mammo that the learning curve is extremely fast, especially for the radiologists who are already involved with breast imaging. It's almost no time they can get used and, like me, fall in love with the contrast-enhanced mammo. And it's very obvious that the contrast-enhanced mammo can detect more cancers compared to just regular mammo. And it works as a diagnostic and a local staging. It works in so many ways. The difference between and the MRI, it's very short time. We have to finish all our imaging within 10 minutes to be diagnostic. Okay, so it's very short procedure. It's accessible to a large number of patients. We can accept so many patients. For us radiologists, very short reading time, which is very nice for us. And it has similar sensitivity to MRI with higher specificity. And we can use it even for the patient when she has a renal failure after the consultation of the nephrodoc in comparison to MRI, where gadolinium is absolute contraindication in cases of renal failure. It is less expensive. and it's very well tolerated and accepted by the patients. And to go now to dive in the clinical indications, first I would like to talk about the using of contrast-enhanced mammo in symptomatic patient as a first-line modality for their diagnosis. And this is an article that discussed using a contrast-enhanced mammo as a first modality for diagnostic in case of palpable abnormality. So a patient presenting with palpable abnormality, instead of doing a regular mammo, then try to work out this palpable mass by a contrast, I will do a contrast-enhanced mammo from the beginning. Okay, this means I have better specificity, better positive predictive value, and better accuracy. Okay, which means I can avoid negative biopsies. So I spare the patients these biopsies. This is another article which I love. They said because it also have high negative predictive value, and this is extremely important for me. When I reassure a patient and I tell her, thank God you'll have nothing, I just want to see you after 1 year for just your screening mammo, I want to be sure when I release this patient that she has nothing. So it's very important that contrast-enhanced mammo have negative predictive value. And in this study, they found all the masses that showed negative enhancement in the recombined images, but seen by ultrasound, all of them were benign. Okay, so this is what means the high negative predictive value. And it also, when they use it like this way, they found additional cancer in the contralateral breast. So this is very good. Just an example, Mrs. G, 56-year-old, she presented with right breast mass. I think from the other building, if they see this mammo, they will know that this patient has cancer. Okay, so one surgeon raised the question, why do you want to bother a patient very well known to have cancer with a contrast mammo if we know she's already cancer from the clinically? Now, it's very obvious that this mass will enhance, but what did the contrast added? Not only the initial cancer, but also the extent. We have a segmental non-mass enhancement extending from the nipple up to the posterior third. Not only that, there's an enhancing nodule in a different quadrant. Okay, this is hair index cancer, very ugly, involved the skin. This is the area correlating to the non-mass enhancement that was seen on the recombined images. This is the axillary lymph node. And when we looked at the tiny enhancing nodule in the lower inner quadrant, we just found this tiny skin nodule. This was missed in the first ultrasound that was done. Okay, because the person who did the ultrasound thought that this is a sebaceous cyst because it was involved in the skin. So biopsies were taken. It was invasive carcinoma, grade 2. The axillary lymph node were involved, and the skin nodule was a metastatic deposit in the skin in a different quadrant, which was changed this management of this patient. Another. Sorry?
You know, this is the thing. I suspicion to go directly to.
Exactly. Okay. I wish my surgeon can hear you. Another patient, 60 years old, presented with a left breast mass, and when we did her the heterogeneous dense, so we're not that sure, but because it was palpable, we know there's focal asymmetry in the lower outer quadrant, and the recombined image showed this hair mass, and I had an additional enhancing focus in the other breast. Okay, when we did the ultrasound, this is hair palpable abnormality, and this is the mass that was seen in the other breast, irregular in shape, and also I have a group of coarse heterogeneous calcifications. So core biopsy was done from both lesions. In the left breast, it was invasive lobular carcinoma, and in the right breast, it was only sclerosed intraductal papilloma. We did also stereotactic biopsy from the calcification that turned out as ductal carcinoma grade 3. So the patient did bilateral lumpectomy. In addition to the DCIS, she has LCIS in the right breast, and multiple intraductal sclerosed papillomas. And she's doing very well. This patient's still following up her annual follow-up by contrast mammo. Now, her daughter was a doctor, and she strongly believed after this findings with contrast mammo, and she said, every year I want to follow my mom with contrast mammo. Okay. Next is the pathological nipple discharge, and this is a very nice article where they saw that the diagnostic accuracy when using contrast-enhanced mammo for pathological nipple discharge is much, much more using the contrast mammo. Okay, it will give you better extent of the disease, and with you will know the case is multifocal or not. This is just Mrs. W, 68 years old. She presented with a bloody nipple discharge. She's in the healthcare system, so she came with a cytology report saying suspicious cytology without doing any imaging. So with this cytology, we decided to do contrast enhanced mammo for her. We can see very clearly that discrepancy between the two breasts, okay? But there is also focal asymmetry in the other breast. Now, the beautiful about contrast enhanced mammo, it gave me the extent of the disease in her right breast, but it also showed complete negative enhancement in the left breast. So here when I say good negative predictive value, so maybe we will continue digging on this and doing ultrasound and doing MRIs and doing so many investigations because we want to make sure. We know this is really suspicious, so we need to stage the other breast, but in one appointment, in one compression, I got the answer that she has a disease in the right breast and completely negative left breast. Okay. In the ultrasound, there was diffuse non-mass area with very subtle ductal dilatation. Core biopsy were taken from this, and it was high-grade DCIS. Okay, and because of this extensive distribution, mastectomy was suggested, but the patient refused, demanding more accurate procedure and investigation. We did MRI, it just show the same exact thing. So for me, this was a useless MRI. Next is breast pain. In cases of breast pain, usually CM is not the first line modality. The diagnostic yield is very low, and most patients turn out to have nothing. So in cases of breast pain, we just work with the normal mammogram and we reserve contrast for the patient if there is any equivocal in the conventional imaging. Other symptoms in the breast like skin changes, nipple changes, axillary changes. Now this is like a controversy, okay? And we work with the referring physician. How suspicious are you with this patient? If he said, no, I'm extremely suspicious, we will go ahead and do our contrast. But if the suspicion is low, we start with the conventional imaging. This is a 42-year-old lady presented with axillary mass. And we can see from her, we did contrast enhanced mammo for her. Okay, it was very huge palpable mass. And we can see the extensive lymphadenopathy, okay, and one small nodule, okay, which from the lucency, it was suggested that this is intramammary lymph node, okay? But what did the recombined image show us? Now, we saw the intramammary lymph node, but we saw 3 more tiny enhancing lesions in the breast itself. This is the intramammary lymph node, and this is her axillary lymph node. And these are the small lesions. It's around 4 millimeter, 5 millimeter, 3 lesions, just like the one we saw. Of course, the recombined image guided us for the location of these. So we were extremely digging. And this patient, mashallah, had a huge breast. So we took a lot of time to find these tiny lesions. And we decided to biopsy the 2 furthest masses because they were 8 centimeter apart. And the markers were in the correct position. And both biopsies came back as invasive breast carcinoma. Next is the diagnostic problem solving in equivocal studies. Okay, sometimes the final mammographic assessment is uncertain because of breast density, because of previous surgeries, because of subtle findings. So we need something extra just to make sure. Okay, so this is Mrs. S. She's asymptomatic. She comes for screening because she has positive family history. And 2019, there was nothing. Okay, there was like just a scattered microcalcifications. We've thought nothing about it. In 2020, she came back. Yes, there was a minimal increase, but still, we see central lucency. So we're thinking central lucency, this is benign calcification. We don't want to do anything for her. Okay, we don't want to do any harm or extra investigations. COVID happened. She lost follow-up for 3 years. She came back in 2023 with this much calcification. Now, the morphology is central lucency, but we have interval increase and we have segmental distribution. So we're in a dilemma, okay? So what we did contrast enhanced mammo for her, and we saw this extensive enhancement in the left breast. In the ultrasound, diffuse non-mass area with very, very tiny hypoechoic lesions. Core biopsy was done, but the biopsy came back as sclerosing adenosis. We did not accept that. We said this is discordant, and we advised the patient for a rebiopsy, but she refused, saying she wants something more. Okay, and we did MRI for her just to show her the extent, and I begged her to repeat the biopsy. Finally, she agreed. Okay, so then we did stereotactic biopsy to make sure we're getting from a good area of calcification, and then it came back as invasive ductal carcinoma. This is her mammogram after chemotherapy. Okay, we see complete resolution of the non-mass enhancement that was seen, and the post-operative histopathology showed complete pathological response. Another patient, she came with a palpable mass, but this patient, 2 months ago, she did mammogram, and her mammogram was reported as BIRAT 2. Okay, and because she was my patient, she came to me. Okay, and in that palpable region, I see this area of shadowing. It's just an area of like non-mass, it's just shadowing. I cannot pinpoint or just have an area. So, and she had multiple fibroadenoma stable for years. I pulled her mammogram. I don't see anything specific in the upper outer quadrant. So I said, maybe, okay, I'm not sure. I pulled the previous, no significant interval change. In the CC, no significant interval change. In the extended CC, we see maybe something is happening in the outer part, okay? But she told me that she missed her period for 2 weeks, and she's extremely congested, and she has severe breast pain. So I told her, just come 1 week after you get your period. Let's repeat the ultrasound. I was really hoping I will find nothing after she gets her period, okay? But repeated ultrasound showed the same abnormality, okay? And here I decided to do contrast enhanced mammo for her, and this is what I saw, okay? She has extensive non-mass enhancement in the upper outer quadrant, most obvious in the extended CC. So because I saw this area under ultrasound, I did vacuum assisted biopsy, and it came back as invasive lobular carcinoma grade 2. Okay, and this is her recombined images mid-cycle after she took the chemotherapy, and we can see there's interval regression of the non-mass enhancement. Next is preoperative local staging. This nice article said, yes, when we do contrast enhanced mammo for local staging, we will end up doing more biopsies, okay? But doing all these biopsies means I change the type of surgery, okay? That maybe if I didn't do this, a cancer will be missed in the first surgery, and the patient will come back with a recurrence. Okay, so using CEM in the preoperative local stage is really important. Okay, this is a 41-year-old. She did her mammo abroad. Okay, she just came with a report with BIRAT 5, but I have no images. So we did her contrast enhanced mammo as a local staging in addition to the diagnosis, because we don't have anything mammo for her. Okay, we see this area of calcification. Okay, but the area of the enhancement is so much more and bigger than the localized calcification. Okay, she has very tiny nodules scattered all over the place. Okay, stereotactic biopsy was done, and it came back as invasive ductal carcinoma with invasive lobular carcinoma. Okay, so in this case, the surgeon was planning to do just wide local excision for this tiny area, but she ended up with a mastectomy. Next is monitoring neoadjuvant chemotherapy response. Okay, and this nice article just say that the contrast mammo is a beautiful alternative for the high cost and lengthy procedure of MRI. This is a 26-year-old. She presented with a breast mass for a few months. Her father brought her to me saying, oh, my daughter have a fibroadenoma. Can you just take a look? And this is what I found. Okay, it's a large mass, irregular, ugly mass. Okay, so with a satellite mass adjacent to it and axillary lymph nodes. So we did contrast enhanced mammo for her, and thank God we found this lesion, but we also found the satellite lesion and we found an area of non-mass enhancement. Okay, so I did the second look ultrasound. We found this small non-mass area. Okay, but because the distance was less than 3 centimeters, the surgeon said, I don't want a biopsy from this non-mass enhancement. We ended up just doing a biopsy for her original mass, and it came back as invasive carcinoma. Okay, and the lymph node as metastasis. Okay, she started neoadjuvant chemotherapy, and this is mid-cycle contrast-enhanced mammo, and we can see there is significant improvement of her cancer, and the non-mass enhancement completely disappear, the satellite lesion disappear. When we see the ultrasound, you can see still there is an area of distortion and non-mass area, but the contrast-enhanced mammo told me that the enhancing lesion is just the tiny nodule. Okay, maybe if I do only ultrasound for her, I would think that the chemo did not work. Okay, but doing the contrast enhanced mammo means I can show the true extent of response to the chemo. Okay, and this is when she finished all chemo cycle, complete radiological response. It was very beautiful. Her surgeon was not convinced, insisted on doing MRI for her. Okay, and it added nothing. The personalized high-risk screening, we already have 2 talks about it. Okay, so I'll go very quickly. According to ACR, the high-risk group is more than 20%, and it is for BRCA mutation, patient untested with first-degree relative of BRCA mutation or someone with chest-4 radiation. The moderate risk between 15 to 20. It is for the dense breast. Dense breast by itself, it's a moderate risk. Personal history of atypias, LCIS, strong family history that does not meet the high risk, or personal history of breast cancer. This is moderate risk. And we know that the high risk, they have their own scheduling with annual MRI and annual mammo, and they're safe. But what about the moderate risk? The moderate risk annual, the recommendation is only annual mammo, and annual MRI is not routinely offered for these patients. So in my opinion, because I'm a CAMA lover, I think it's worth it just to present it for them, okay, and to give them that extra push. Okay, this is a very nice literature review that supports that contrast enhanced mammo can be a very useful screening tool for these group. This is another one, okay, that looked at the personal history of breast cancer, and yes, contrast enhanced mammo increased the detection of malignancy and reduced the interval cancer. Another article that looked at the dense breast and the intermediate risk, and also high sensitivity compared to mammogram, and if we have negative recombined images, okay, adding an ultrasound will have nothing. So just having a recombined images is really good. Okay, and because of the amazing new screening modalities and the amazing new oncoplastic surgeries, we have a lot of patients coming with post-operative changes, and we need something. We all know Dr. Mirat's lecture about the fat necrosis. With all the surgeries, we are stuck. So doing a contrast enhanced mammo for the post-operative cases, okay, really good, because it detected more cancers and it has a higher positive predictive value, which means I will reduce mortality in these things. Mrs. I'll take like two minutes. Okay, I'll run. This patient, she has extremely strong family history. 2 of her sisters have breast cancer. 1 of them passed away, and she's coming for screening. In 17, we just did regular mammo. 18, the contrast mammo was introduced in my hospital, so we offered her contrast enhanced mammo. 18 was beautiful and nothing there. In 19, we have a new enhancing lesion that was seen only in CC. But when we pulled better position in MLO, we found a developing asymmetry, enhancing. We found the mass, and it was invasive ductal carcinoma. For her, MRI was done because of the location of the mass. It was posterior, so we were worried about chest wall invasion. And now she's following up with contrast enhanced mammo, even though there is architectural distortion, but because there's negative enhancement, I'm not worried about it. Okay, and this patient, she came, okay, for her screening. She did surgery before for a high-risk lesion, and she's coming early for screening. Okay, then we saw there's architectural distortion. We pulled her previous. to us, we thought that this distortion was getting worse, okay, compared to previous studies. So we did tomo. Yes, there is distortion, okay, and we don't know if it's new or suspicious or not. So we did contrast enhancement for her, completely negative. And this is what I love about it. We avoided the biopsy. Last is we can do it when MRI is contraindicated. Now, when is the MRI doing better? Okay, I can't say that MRI is useless. Okay, okay. If the location of the mass is posterior, I want to rule out chest wall invasion. Of course, if there's a plus implant, I can only rely on MRI. To know the extent of the lobular disease, there is a lot of articles, okay, but most of them said, yes, MRI higher sensitivity, but CEM have higher specificity, which some people, some experts say that contrast enhanced mammo pick the clinically important abnormality, okay? And intraductal, finish, last slide. The intraductal lesions, better with MRI, especially if the lesion is less than 5 centimeters, but it can be seen in contrast. So I start with the easy contrast, then I go for MRI. And in the next lecture, I will tell you how this changed my practice in my institute. Just CM is a lovely modality that I'm in love with. It's faster, cheaper, higher sensitivity, and thank you so much.
Good morning. Dr. Samra, know that everyone that organized these events usually will have to skip his lecture. I did it last year. I had the honor to present it this year, but I'm going to be very fast because we have a lot of speakers that we really would love to hear too. First of all, it's really good to be back. This place really feels like home for me. Let's start the lecture and then we'll go. I'll just make, I know it's not a new topic, but I just need to emphasize on a few points that we can, if we can all agree with, because some of them are debates, okay? I have no disclosure. Why it's important that this category, it's, first of all, I would like to apologize if I used a pregnant and lactating female versus normal females. It's not that they are not abnormal, they are superwomen for me, but it's just if I said. First of all, it's really important to pay extra attention to these people because we know that the breast of a lactating or a pregnant female looks different in imaging. And it makes sometimes a delay in diagnosis of breast cancer, which lead to a very poor outcome in most of these patients. And actually, it's increasing because a lot of women choose to delay pregnancy until later age, okay? So in this, the spectrum of this lecture, very fast is discussed the recommended and diagnostic guidelines, where we might have one fight here. Normal physiological appearance, it's okay, and describe the features of benign and malignant lesions, and there's another small fight in the end, okay? First of all, I'll tell one thing, and I want you to say if you agree or not. In screening for a pregnant or lactating female, if she's 40 and above average risk or 30 and above, 30 with high risk and above, we should do mammography with tomosynthesis, and we can ultrasound. Who do agree with this?
Agree.
خلاص خلصتيها كده؟ ما اديتهمش كورس. Okay, for our technologists back there, have we ever did this before? Before I come in the early? Yes, sometimes we are afraid of doing this, but actually ACR emphasized that mammography is safe during pregnancy and lactation because the radiation dose is negligible for the fetus. It will not harm, okay? So it's very important that especially if a woman that is in the screening period, it's time for her screening out. We shouldn't ask, are you pregnant? Are you not? If it's her screening time, and at least if especially she is high risk, let's go and do it, okay? And I know it's the hardest part is to take a consent or to convince her that it's okay. I know. I'll leave it to your talent to tell her how to do it. Yeah, I know nobody agree, but in the ACR, they say that it's for the screening, but this maybe is not discussed. We cannot convince other normal women, non-pregnant and lactating, to come for screening. How would I convince a pregnant woman to come to screening? But it's okay. I mean, if you can do this, you're great. You're on the right track. It's okay. However, for the MRI is contraindicated during pregnancy, of course, because the gadolinium is class C, a non-risk to the fetus. While it's safe for lactation, we usually use it for high risk, mainly in lactating, and it's completely safe for any woman doing MRI with contrast to continue lactation after this. And not a big amount of the contrast reached to the baby, and it's not harmful to him. Okay. It's best to do bumping or anything before mammography or before ultrasound. Of course, if she's lactating or before MRI, it's better to do bumping or breastfeeding to get relatively better results and to be more relaxing to her. Okay. In diagnostic, this is easy. Just do it fast. If she's pregnant, we would start by ultrasound. Okay. But if the ultrasound is negative, if the patient comes with a palpable lump and then the ultrasound is negative, we should go to mammogram. I'm sorry. And if it's positive for suspicious lesion, we still go for mammogram because we know she might have DCIS or something that the disease extent is larger than what we think. Okay. If she's lactating, we would treat her as a non-lactating, non-pregnant woman. If she's below 30, we'll start ultrasound. Above 30, we'll start by mammogram, followed by ultrasound. Okay. Just one look at this slide. Can you see one thing is missing? لا مش دي. It's not one number missing. Okay, good. We'll come to it later. If she is diagnosed with breast cancer at this time, we will go for bilateral diagnostic mammography. We need to know the bilaterality, multicentricity, and true extent of the disease. They say, according to the ACI, we don't have to do ultrasound, but we will do ultrasound. We know we will do ultrasound. We will do everything that we can to know what we can do with her. Breast MRI for lactating female, although there is high parenchymal background activity, but it changed the decision of the operation in up to 28% of a patient in a study when they did for a lactation female MRI prior to the procedure. If she's taking neoadjuvant chemotherapy, it's like we can go how there is no much data or guidelines, but if she's in pregnancy, we can do ultrasound for follow-up, and if she's lactating, we can go with MRI for follow-up. As we go to the procedural, we know core biopsy is the best. Ultrasound guided core biopsy. Okay. Is it very safe? It's very safe to lactate after it. If there is milk and blood in the milk or lidocaine, it's okay and safe to lactate after this. Is it no risk or less risk or same risk as a normal person? No. Higher risk, bleeding, infection, and formation of milk fistula. Okay. That's why we try to use smaller gauge, lesser, fewer passes in these females, and a bandage and pressure and things like this. Most milk fistula, and we have to consent this female about these possibilities, okay? And we have to tell her that we might even need to suppress lactation to stop the milk fistula if it didn't stop spontaneously. We can go for stereotactic, but you know it's larger needles. It's better to try to get it by ultrasound. MRI guided for lactating is okay. We can do the mammography to see the mark or anything after the biopsy. And for the preoperative localization, just like any non-pregnant and non-lactating female. Moving to the physiological, you know that estrogen make enlargement of the terminal ductal locular unit, while progesterone make more growth and more differentiation into colostrum cell epithelium. As we know in mammogram, it's very dense, but yet it's important. You have to see the calcification. You might see calcification in lactating female, but it's usually diffuse and nice and fine. But if it's just clustered or something, it's okay. You can go to biopsy to just confirm. You should never miss a cancer in this category. You can get your suspicion to the highest level. It's okay. It's allowed, I mean. In post-lactation, it returned back to normal about within 3 months of cessation of lactation, okay? In ultrasound, we all expect that it will become more echogenic, more dense, more glandular tissue. We'll start to see this calcification foci, and still we may get negative results if it's DCIS or if we misdiagnosed a mass as benign. If we saw like it's a nice fibroadenoma, it's benign, take care. I didn't mention biopsy previously for a reason. Yeah. In MRI, as expected, increased fibroglandular activity, volume, increased vascularity, which will reflect as increased T2 signal and increased parenchymal background enhancement. Yet still, the sensitivity to catch cancer in these lactating females is up to 100%, despite the high background enhancement. Okay. Contrast enhanced mammography, there is no much studies, and this is for you to go study this part on this category, okay? And molecular imaging, as Dr. Abdelatif know, we did it once. It's very high background activity, so it's not really helpful, and there's no recommendation in lactating. In, of course, pregnant, no. Last thing, go fast. As we know, most of the lesions that appear in a pregnant or lactating woman are benign, okay? But the problem is the breast cancer usually appear, we detected in them very large, very advanced with worse outcome. And we have this curse of, clinicians who said, you have a mass, no, it's hormonal effect. Still we have this, okay? Some disorders are specific to pregnancy and lactation, but most of them are just as any other woman. Moving fast, I will not focus on the benign because I need to say something in the malignant. We know the galactosile, most common benign lesion, and it has this beautiful appearance of fat and fluid levels, but we all know it's not always that easy and not simple. Sometimes it's complex, and sometimes we still have to biopsy. If there is portions of old milk and water, it will become heterogeneous. It's okay. If you're not sure it's 100%, if it's not by rats too, biopsy. Okay, if it gets infected, it might turn in abscess. If it ruptures, it will produce inflammatory reaction around it, which will make it look suspicious with posterior shadowing. Go for a biopsy. It's okay. Lactating adenoma, it's adenoma. I know I might be shocking you from the too much biopsies I will mention in this lecture. In lactating adenoma, which is a benign disease, the exact histological nature is unsure whether it's genuine to the lactation or the pregnancy, but most of them regress after cessation of lactation. It would usually appear very nice, very round, very oval and homogeneous, but it can come heterogeneous as well. But even if it's nice and oval and looking nice, you need a biopsy. You need a biopsy to confirm this, because breast cancers in this category of females can come as well-defined lesions and nice oval lesion. Plus, all BI-RADS 3 studies that said that an oval nice lesion is a BI-RADS 3, mostly fibroadenoma. These studies were conducted on non-pregnant, non-lactating females. So we don't have studies on this category that would say this applies to this category of patients, okay? So not everything is fibroadenoma. You just even sometimes have to do it. Sometimes it goes into fibroadenoma, into lactational changes that would make it look even suspicious, very suspicious, and you take a biopsy and it's fibroadenoma. Like, oh, it's okay. I'm fine with this, but I didn't miss a cancer. This is the most important thing. Fibroadenoma can stay at the same, or can go lactational changes, which will make it heterogeneous. However, we still need to go for a biopsy for any new or growing solid mass in a pregnant or lactating. Sometimes the patient comes with a very nice mass. Did you have it before pregnancy? No, I never did imaging. I'm sorry, I have to biopsy. Sometimes patient coming with a mass that was present, but it's enlarging. It might be lactational. I'm sorry, I have to biopsy. Mastitis and abscess, it's very common. Actually, almost 1 in 4 lactating female will get a sort of mastitis, and then it will up to only 5 to 11% will go into abscess. We need mainly to aspirate it, and we must do a clinical follow-up, because you know that it might not be an abscess, it might not be a mastitis, it might be, likewise we say, mastitis carcinomatosis. So you just push the patient, even if you feel 100% better, you come back to me, I have to see you myself, okay? Granulomatous mastitis, this is a case, one of my cases, it has a very wide range. It's not what we think. It's really mainly related to the lactating females. It develops usually within 5 years of pregnancy, okay? And it's usually what we say, it's the disease of exclusion. You see abscess-like, mass-like, or whatever. It's not getting better with treatment. It mimic everything. It mimic malignancy, it mimic mastitis, diabetic mastopathy, any kind of granuloma and mastitis. If it's not responding to treatment, take a biopsy, okay? Because you will need a different type of treatment for this category, okay? And you shouldn't let it until it's become very extensive. Lymphadenopathy is very common and we should be careful. Only just by that 3 mentioned here wise, if it's very nice and looking just inflammatory, follow it up. If it's not responding, you know. And ectopic breast tissue, I just need to say one thing in it, it's just breast tissue. Everything in breast can happen in breast, can happen in axillary breast, okay? If it's not connecting, you know that most of women come with this complaint that it appeared after lactation, okay? We should assess it completely because it still might develop all the pathologies, including cancer, okay? And if it's not connected to the glandular tissue by duct to the rest of the breast, it will develop mastitis from occlusion because she doesn't have a way to get the milk out. This is a nice case. I saw it once in my life, and I'm one of the lucky who saw 60 cases worldwide. A young female came to me. She's in her 20s. She's pregnant, and once the pregnancy started, she realized that her breast is growing extensively and rapidly and persistently, and the ultrasound is negative. Of course, we couldn't do mammogram. It have been negative still, and everything is negative. By searching, it was what we say gestational related gigantomastia or macromastia. It's of, we don't know really the exact pathology under it, but it's actually we may need to reach for mastectomy sometimes, although it's completely benign, but it happens. It's rare, but if you saw it, don't matter. Okay. No, it's very hard. Back pain, ulceration. Wow. As regard the breast-associated breast cancer, pregnancy-associated, this is the main topic. It's just 2 slides, don't worry, okay? Number 1, that it's defined by breast cancer that occurred during lactation and 1 year after delivery, okay? It's 1 in 3 to 10,000 of pregnancy and 3% of all breast cancers. It's usually detected larger with higher rate of nodal metastasis because they believe that additional hormonal effect may lead to progressive growth for it. There are new, it's usually ER negative and HER2 positive. There is a new terminology that we may hear, that pregnancy-associated breast cancer and postpartum breast cancer. Pregnancy-associated is about 4% from all cancers that happen for female under the age of 45. And they say that although it having pregnancy, where the hormonal flare, it still has a prognosis similar to non-pregnant, non-lactating female. However, the one with worse prognosis is that one with postpartum breast cancer, which happened in the time from 5 to 10 years after pregnancy, which account to almost up to 55 of women who are younger than 45, okay? They say it has worse survival, maybe because of the tissue remodeling process that happened with the involution of the breast tissues. It's all suggested, but we still stick with the pregnancy-associated breast cancer. It's usually manifest as painless mass. However, we also lactating female coming with mastitis and bleeding per nipple, and it turned out it's not responding to treatment, medical treatment. So we usually find that it's mastitis carcinomatosis, as we said. Everyone saw it. The point is we get suspicious with that one, but we don't get suspicious with the nice, well-defined one. Okay. Take care, it might be nice, and it might have posterior acoustic enhancement. And in a nice paper, I read that those with posterior acoustic enhancement are usually of higher grade, okay? For the treatment, she can have everything. You have to know this. This is more not radiology, but we have to know it. She can go for chemotherapy after the 3rd month, after the 1st trimester, it's okay. She can go for surgery, but she cannot go for radiation. So usually if it's detected late in the pregnancy, we can do breast conservative surgery if it's okay, because after delivery, she will go for radiation. But sometimes if it's detected in the early pregnancy, you will have to go for mastectomy. You will not wait 9 months, okay? They can take chemotherapy, it's okay. But the other, like endocrine therapy, HER2 directed, is usually not contraindicated or not given during pregnancy. لا خلاص أنا أسرع. Last thing, this one I added for this. All of us saw that we think there is a relation. We know what we know, that we think there is a relation, although a meta-analysis study of 25 studies said that there is no risk associated between IVF or fertility treatment with breast cancer, okay? This is a good news. And also women who had previously breast cancer can go for IVF after they get treated. According to literature, it's safe. However, since a study said that long-term treatment with IVF may lead to breast cancer, and also if patient with high-risk BRCA mutation, we don't know, we can't see there is risk, but we don't know if there is risk. You see that line? And also there definitely no study said that if a patient has already breast cancer, small, and she went for IVF, if it's going to enlarge or not. No one would do this. No one would get a patient with cancer and get her into IVF. So also most patients going for IVF are usually, you know, that infertility, dense breast, and older age are actually risk factors. So the key is let's do a personalized approach, okay, for these patients. It's not just for high-risk patients. They know we need to deliver our message to the gynecologist. Please, before starting these treatments, do just a risk assessment for these females, okay? That's it. Today we call mammo. If she's tested for BRCA, she can start with before IVF MRI, and then at 4 to 6 months from pregnancy we can do ultrasound. But this is the right thing. Okay. The conclusion, everyone, you know. Thank you so much again.
Thank you.
I hope I was fast. And one thing I want to say, I'm not biased, but I'm really thankful for being here for the next year. And I really mean it. This place, I owe it a lot in everything I am now. And I really am happy with this gathering, because this gathering last year and this year added really to our knowledge and our planning. Please, I believe this is not, Dr. Samara, this is not the end. Dr. Mustafa, you know, we'll wait for the next year conference, okay? Okay, see you. Thanks.
Dr. Noor is a woman in breast imaging radiologist with over 18 years of experience. She pursued a women's imaging fellowship from King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. She completed her breast imaging fellowship from the University of British Columbia, Vancouver, Canada. She has a master's degree in executive health administration from the University of Alabama. She is currently working as a senior consultant in breast imaging at Johns Hopkins Aramco Healthcare.
Assalamu alaikum. Thank you very much. تقبل الله طاعتكم يوم الجمعة. طيب. I'll try to go through things in a basic and advanced way. So we agreed, both of parties in this meeting, how to approach the assessment of axillary lymph node in a proven cancer cases. How can I turn the page up, page down? Space, okay. مو ماشي عندي. Page up, page down. Really?
Do you need to move it? Okay. Oh, هنك.
Okay.
أنا مش عارفة أنا دوست عليه بس هو بايق.
This one is working. طيب, objectives will be imaging axilla modality of choice, impact of axilla assessment on breast cancer staging and management, radiology versus clinical assessment on staging, and sentinel lymph node radiology perspectives. We know that accurate staging of axillary lymph nodes remain the cornerstone of breast cancer management because we stage right. It serves as both a key prognostic indicator and a critical determination for systemic and surgical decision making. The presence, number, and extent of axillary lymph nodes metastases are among the most important predictors of recurrence and overall survival in patients with breast cancer. It is directly influencing recommendation for adjuvant systemic therapy, regional radiation therapy, and extent of surgical intervention. Now, traditionally, that was till the early 90s, axial lymph node dissection was the practiced method for staging breast cancer. And it's associated for sure with significant morbidity, including injury to nerves and major blood vessels, infection, seroma formation, and lymphedema. Alternative measures or tools have been evolving over the years. It can be imaging or non-imaging or combined. And just to go through things in a more comprehensive way, we know that one of the most common used system in staging rely on tumor size, presence of nodes, and distance metastasis. So presence of nodes, their size, their number is a major component of staging our patient and accordingly the management. To go through the physiology behind, just to understand the imaging findings is essential. So the tumor cell go travel through an afferent lymphatics and going within the lymph nodes through the afferent. They rest at the cortical region, specifically at the subcapsular sinus as a single dot or focus. Then they can accumulate and coalesce and create a larger focus, then engulfed within the medulla. Additionally, we can see image-wise as well, a morphology changes related to new vascularization because of the development of a new mass or enlargement of the axillary lymph node. In radiology, we know that ultrasound is the relied heavily on assessment of the axillary lymph node. It's widely available, real-time capability, low cost, reproducibility, and can be used for guidance for biopsy. The component that we need to assess, I'm talking about the basic things and how we can apply them on our daily practice. We can assess morphology, shape deformity, cortical bulging being rounded, the ecotexture, the overall size versus the cortical thickness, any abnormal peripheral cortical flow, plus morphology changes, number of diseased lymph node. What are the ultrasound concerning features? Does the overall size matters? Actually, studies proves that it doesn't matter, the overall size, as long as the morphology, the ecotexture does not change. Cortical thickness more than 3 millimeter, more than 3 millimeter will start be concerning about involvement of the lymph node in the presence of primary disease. Focal or eccentric cortical bulging, one of the features that are worrisome for and warranty biopsy. Cortical hypoechogenicity, loss of fatty hilum, rounded or irregular shape, presence of calcification, if the primary tumor has calcification, and peripheral blood flow in addition to morphology changes. This is one of the study that shows that classification of sonographic appearance of the node on the basis of cortical morphology. If we started to talk about morphology and measurement, we are talking about the cortical part of the lymph node to start with as an initial feature indicating involvement. The same article, for easy approach, divided the lymph nodes, which is for me it's a very important educational way or approach, into 6 types, and accordingly the chance of having the disease is based on the morphology and the proportion of the cortex versus the medulla. So type 1, 2, and 3, when we have mostly hyperechoic lymph node with thin cortex. Type 4, when the cortex is still thin, but it's lobulated. Type 5 and 6, when the cortex is thickened, whether it's diffuse thickening with loss of fatty hilum or it's a focal bulging. The one at your left represents type 1. It shows mostly diffuse echogenic with barely you can see a thin cortex. The one at your right side, it's type 2, uniform hypoechoic cortex with less than 3 millimeter. Type 4 at the top is when the cortex is still thin, still less than 3 millimeter, but it has diffuse lobulation. Type 5, when we have a focal thickening, but still we can appreciate, I'm not sure if this is okay. Oh, it's working, but because it's working outside the screen. but yeah, even the mouse, I'm not sure if it's working. Type 5, when we have focal cortical thickening or lobulation and it became hypoechoic. Type 6 is when it's diffusely involved by the disease and it's totally hypoechoic. For type 5 and 6, the last two or the lower two, the positive predictive value of getting cancer and the necessity of doing the biopsy to exclude malignancy is higher. So the chance to have disease in type 5 and 6 is higher. Now, there are a study includes the size and the pathology findings. So the mean size of a benign and malignant, it's the same study. The mean size of benign and malignant nodes were similar. So the overall size is not an early manifestation of a disease if it's altered. Therefore, cortical morphology feature hypoechoic cortex appearance to be greater important than the nodal size, the overall size. In type 6, appearance appeared significantly smaller than type 2 and 4 as per the table here. So sometimes it's not sometimes, it's most of the time in early stage, it's not the size. Type 2 and 4 are showing a benign feature and sometimes they appear larger than type 5 and 6. The other manifestation or presentation of a disease within the axial lymph node is having calcification. And this happens when the primary disease has calcification. Neovascularization is one of the components that need to be assessed during the ultrasound of the axial lymph node. And this is because of the growth of a new deposit within the lymph node. So definitely there will be a new vascularization. We don't assess the vascularity alone. It has to be assessed within the entire context of having a change in morphology, change in the cortical thickness, disappearance of the fatty hilum, and additional vascularity as seen within crossing the lymph node. There are a lot of study, in addition to the features we were mentioning, it just focused on the cortical manifestation or changes within the initial stage of the disease. And it's all support the concept of having a cortex is the primary predictor of the disease involvement in early stage. Additional, in this study, additionally, they added the long axis, short axis, loss of fatty hilum and lobulation of the cortex. The predictive value of the ratio was more toward of being less. So compared with normal lymph nodes, the short axis of metastatic lymph nodes was significantly larger. Their shape were more of circular, and the ratio between the long axis and short axis was smaller. Now, we need to know that not all the tools, or as mentioned by a colleague, it's not one size fit for all, so not all tools can answer all our questions and our surgeon question. Ultrasound can identify the lymph node, but they cannot differentiate sentinel lymph node from non-sentinel. No role in micrometastasis cannot be seen by ultrasound, no matter how we were meticulous to assess the cortical thickness, alteration in the cortical echogenicity, or lobulation. There are anatomical limitations in deep group lymph nodes, although Dr. Al-Mazrou'i yesterday showed us an amazing miracle manifestation of how deep they can go. There are false negative, and they are inevitable, and 16% of malignant sentinel lymph node biopsy has normal ultrasound features. Now we need to know that on staging, it's not only imaging. It starts with clinical. So there should be a palpable or non-palpable lymph nodes. So the staging, the initial staging for any disease will start by clinical. All the guidelines are going with clinical staging, but this has to be assessed by radiology. A lot of data and articles, they support the role of imaging-based axial lymph node staging and sentinel lymph node biopsy as the standard of care for axillary management in women with a diagnosis of breast cancer before and after neoadjuvant systemic therapy. I'll go more practical. So what we others expected or surgeon expected to have within the report when we talk about axilla ultrasound. We need to talk about morphology, shape deformity, cortical bulging, having rounded or which is all under the shape deformity, the echo texture, the cortical thickness, presence of peripheral blood flow, and number of diseased lymph node. I know there are some centers, they change their workflow to accommodate all this to have a more precise, detailed report regarding the axillary lymph nodes. So some centers, they have a separate request for axilla. So they can allocate a dedicated time to fulfill all this needed. I'm not sure if you heard or practiced this, but there is what's called NORAD, which is the reports. This is recently released and provided for me by Dr. Salma. Thank you, Salma. It's released on September 2025. It talks about the nodal reporting system. It's a standardized classification system for evaluating axillary lymph node in breast cancer using 1 to 5 scale to assess the likelihood of metastasis. Now, it is an evolving, or it seems that we are coming into a new era where assessment of the lymph node goes through a different stage, so we have a more precise roadmap for our surgeon. It employs structured flow chart based on imaging features like size, texture, borders, and categorized to lymph nodes, aiming to improve diagnosis accuracy and consistency in axillary staging, which is basically the same when we started using the BIRAD for breast. NodeRAD offers a foundation for more precise staging and is expected to be augmented with machine learning, which is an unexpected milestone, and genomic data for enhancing risk prediction in future. Though it is still undergoing refinement and validation. And this is, we are in this stage. Basically, it will assess the structure in a 5 scale from 1 to 5. The key features evaluation will be in a flow chart. It will assess node, and they will classify it as normal, enlarged, or bulky. The modality used in this case, this tool is the MRI, not the ultrasound. And based on the scoring, the lymph node will be, the management will be planned. The purpose and benefit of having the NodeRAD is to create a common language and framework of reporting and evaluating the lymph nodes, improving diagnostic accuracy, enhancing clinical confidence, future potential, which is what we are in this stage, is seen as NodeRAD is seen as a crucial step toward integrating multimodal data such as machine learning and genomic information. We are in an ongoing reinforcement. NodeRAD is a relatively new system and required further validation. I found a lot of articles talking about this. It seems that this is the era where we need to do a lot of validation for NodeRAD before imposing it on our reports. I'll just touch very quickly on the management of nodes as long as we are talking about it, just to link between the radiological part or perspective with the sentinel lymph node. Now, management of lymph node is part of the management of the breast cancer disease. So it's either systemic chemotherapy, targeted radiation along with the disease, or surgical excision, whether it's a dissection, targeted dissection, sentinel lymph node and clip node, or targeted sentinel lymph node biopsy. Now, as treatment paradigm increasingly emphasizes surgical de-escalation, sentinel lymph node biopsy has largely replaced axillary lymph node dissection. As I mentioned, that it was an early 90s era when we used the dissection with all the complication and the post-surgery lymphedema, infection, all those. Because axillary lymph node status is crucial in the staging, now we need to find an alternative way with less chance of complication to axillary lymph node dissection. The concept of sentinel lymph node is histologically, it assesses the histological status of the sentinel lymph node to predict the status of the regional lymph node based on the orderly spread of the tumor, from the tumor bed to the regional lymph nodes. The principle behind the lymph node, sentinel lymph node, is to assist the lymphatic channel drainage involvement from to improve the metastatic of the tumor cell. And this will track first the sentinel lymph node within the regional nodal basin. Now, in a big study, we call it, it's called B32 trial. It went through differentiating or comparing the axillary lymph node dissection in comparison to sentinel lymph node biopsy. It proves that the trial found no statistically significant difference in overall survival, disease-free survival. In overall survival, the disease-free survival, the regional control for sentinel lymph node biopsy alone versus sentinel lymph node and axillary lymph node dissection. Sorry, I cannot even breathe because almost there. So this is a study recommending omitting the axillary lymph node dissection in early stage with appreciating the value of sentinel lymph node biopsy in comparison to the axillary dissection. I'll go quickly through the technique. It's just a tracer injected within the area of peritumoral, intratumoral, or subareolar, 1 to 5 ml of a tracer, whether it's a sulfur colloid, technetium-99, or other tracer. Then the images took place. It's important to know that there are limitations and the risk factor for failure, like significant axillary disease burden, extranodal extension of the disease, and largely bulk breast tumor. An example of sentinel lymph node, site of injection, and the arrow showed the sentinel lymph node, which is how far from the area of injection, and it shows the initial involved disease. Alternative is the blue dye. We inject, the surgeon inject blue dye. They trace the blue dye intraoperatively to show the sentinel lymph node, which indicate the initial involvement. So in sentinel lymph node biopsy recommended according to the American Society of Clinical Oncology when the tumor size is T1, T2, and or no nodal disease, when the disease is multicentric, when it is DCIS with mastectomy performed previously, and when there is a prior breast or axillary surgery or both. Preoperative or neoadjuvant systemic therapy is planned. In those cases, the sentinel lymph node biopsy is recommended, while when the disease is T3 or T4, it's not recommended. Inflammatory breast disease and DCIS with breast conservative surgery planned and in malignancy. Just before concluding, I'll show a diagram or algorithm for where we can have an integrated ultrasound assessment and sentinel lymph node biopsy. When the patient is stage 1 or 2, when the patient is stage 1 or 2 and axillary lymph node is bulbable or not bulbable, patient will go for ultrasound. If it is suspicious, then we'll go for biopsy. When it's negative, it has to end up with sentinel lymph node biopsy. If it is positive and less than 2 suspicious lymph node, level 1 or 2, axillary lymph node, then sentinel lymph node to be done. If it is more than 2 suspicious lymph node, level 1 or 2, axillary lymph node dissection. If more than 2 or less than 3 in level 1 or 2, we'll do clipping for the lymph node, then targeted axillary lymph node dissection. If it is stage 3 or 4, the proposed management, the same. If the lesion is positive post biopsy, if it is negative, we'll consider systemic therapy and sentinel lymph node biopsy. If it is positive and 3 lymph nodes suspicious or less, clip the node and do targeted axillary dissection. If more than 3 lymph nodes are involved, then it's axillary lymph node dissection unavoidable. So in conclusion, lymph node staging is a crucial step in working up the patient because it's essential to the management, and preoperative imaging of axilla plays an important role in clinical staging. Lymph node imaging using ultrasound is predicated on morphology mainly through the cortical assessment. Node RAD with continuous reinforcement and validation is required and become a central component of breast cancer staging in the era of precision medicine. As the practice of sentinel lymph node biopsy has evolved for patients who undergo upfront surgery and for those who undergo neoadjuvant therapy, the preoperative diagnosis of abnormal lymph nodes help to avoid unnecessarily sentinel lymph nodes biopsy. Thank you.
Thank you.
Assalamu alaikum, يعطيكم العافية. Apologize for this technical delay. I'll try to compensate. Thank you for the invitation. Thank you for the introduction. So, Mammography Quality Standard Act, I have no disclosures. Okay, so we'll try to break down this topic, and we're going to take a break from the multimodality approach to diagnose breast cancer, screen and diagnose breast cancer, and we'll try to make it enjoyable, though the Mammography Quality Standard Act and joy do not go hands in hand. So we'll go through the history, but I really believe that we are at a stage we should review the history to unify and reduce the variability of mammography practice over our country. So that article. So they found that the 35% or more than 35% of facilities was closed at that time because of very poor quality mammogram. And that after the application of the law, all the facilities, in fact, passed the test indicating the good or positive outcome effect of the law. And in this figure on the left side of the screen, the women age 40 who reported not having mammogram have decreased significantly. In the contrary, the women reported having mammogram in the past 12 months was increasing. And this was in their site, and they concluded that there was no reduction of access, and the Michigan law had a positive effect on the quality of mammogram, and it's tougher regulation, of course, but the effect is very positive. In 1992, the Congress enacted the Mammography Quality Standard Act, which was established the national quality standard for mammography facilities in the United States. And by 1 year later, they have their FDA-trained, certified bodies, and it was required all facilities has to be all facilities have to be certified to operate legally, otherwise go in jail, and is administered by the FDA. In 1994, they adopted the quality control manual from the ACR, and it was their interim regulations. And 1 year later, they have inspectors. And in 1999, they issued the Mammography Quality Standard Act's final regulations. They had a few, in a few years after that, until 2003, a few amendments, and the latest amendment was published in 2023, effective September 10, 2024. That's 20 years after the law was enacted. The FDA program certify the mammography centers to meet the quality for the personnel, equipment, radiation, those patient notification, and record keeping, and required all the facilities to undergo annual inspection. And of course, that is after the accreditation. So they have to undergo initial accreditation and then re-accreditation every 3 years. And the QC and personnel document has to be reviewed, and they have to be inspected by accredited FDA accredited approved body, like an ACR. ACR is the largest accrediting body in the US and acts all over the United States, but some states, they have their own accredited body, FDA approved accredited body, like Texas and our. And the yeah, exactly. It is. So accreditation body, they have to undergo certain training, and they have to review the facility standards, clinical image, and they do everything, and they review and they see everything. In fact, it's amazing how they function. They are very well trained. And each facility is inspected annually, and the facility must provide reporting, and they call it self-reporting. They have to report any change in personnel, equipment, quality control, and medical physicist reports. And they charge them a lot of money for every single machine needs to be accredited. And inspection mostly 90% done by the FDA approved bodies, and the inspector. They have a good number of inspectors by now, more than 200 inspectors. And this work under the Code of Federal Regulations, CFR 900, Section 912. And you can find all the information about the accreditation, and you cannot memorize a manual of how you go through things, but whenever you need to find the information, you could just visit that site. They have this is a later amendment in the Part C, records and report. And regarding the personnel, they consider the interpreting physician, technologist, medical physicist, but not the engineer. And there are certain requirements that it is, by the way, the minimum requirement required. And they have to maintain their certifications. They have to be certified, maintain their certifications. And for any new mammography modality, they have to get an 8 hours training before practicing, and this apply on contrast enhanced mammogram and tomosynthesis, but not the ultrasound and MRI. And if you seek any accreditation, the ACR apply. They have a program to accredit the ACR, MRI, and other procedures. And equipment standards, This was amended in 2002, and they prohibited officially any equipment used for general purpose for doing mammogram, and all the facilities need to be accredited, and they give a minimum specifications for mammography machine. And if you see here, the light field illumination is really important, and this was a reason of delay of the use of LED lamp in mammography. Medical records and reports, it has to contain the name, additional identifier, the location of the patient, and the name of interpreting physician. And the final assessment category was amended in September 2020, effective September 2024. And there are also updates in the density. So let's hear this.
Well, paragraph C, subparagraph 1. Each facility must prepare a comprehensive written report for every mammographic examination, adhering to the following requirements. Number 1, patient information must include the name of the patient and additional identity. Number 2, examination details must include the date of examination and facility name, including city, state, zip code, and telephone number. Number 3, the name of the physician who interpreted the mammogram must be included in the report. Number 4, there must be a final assessment of findings, and it must use one of these categories from this lexicon. Negative, benign, probably benign, suspicious, highly suggestive of malignancy, known biopsy-proven malignancy, or post-procedure mammogram for marker placement. In cases where no final assessment category can be assigned due to incomplete workup, the interpreting physician must use one of these categories from this lexicon. Incomplete, need additional imaging evaluation, or incomplete, need prior mammograms for comparison. It is important to note that if the latter is selected, a follow-up report will now be required. Number 5, every mammogram report is to include a breast density assessment, and it must use one of these categories with wording in the report, specifically from this lexicon. A, the breasts are almost entirely fatty. B, there are scattered areas of fibroglandular density. C, the breasts are heterogeneously dense, which may obscure small masses. D, the breasts are extremely dense, which lowers the sensitivity of mammography. Number 6, each report is mandated to include detailed recommendations for additional actions addressing all clinical questions raised by the referring healthcare provider.
Okay, so to summarize, there are 2 new overall assessment statements and 2 new incomplete assessments. And it is why we are using this long time ago, and it is widely used in our clinical practice for too many reasons. There is a difference between the Mammography Quality Standard Act and the ACR, which is ACR is voluntary program, and the Mammography Quality Standard Act under the FDA regulation, and that's a law. So the 2 new final assessment, in fact, they withdraw an alternative standards, and they just restate these again to prevent duplication and misunderstanding. So now you have to use the word known biopsy-proven malignancy and post. Okay. I'll try to be fast. Okay, so you have to use these, and they separated the 2 new incomplete assessment. They separated the previously single assessment, and for the density, finally, it's by law now. They have to report the density and inform the treating physician to take an action. Okay, so these are the densities. Remember that the negative is an MQSA federal regulation, and normal is an ACR, and they approve each other. And the incomplete was separated, and the post-procedure mammogram is now amended in the regulation recommendation. Now, by law, you have to address the clinical question by the patient or by the treating physician has to be addressed in the report, with final assessment report have to be written. You are not prohibited from using alphanumeric assessment like used in the ACR by RADS 1 and 2, but you have to, for example, if you say by RADS 2, you have to add benign. So the medical reports records, they amended this several times, and you have any facility who practice mammogram, they have to keep the records for about 5 years and 10 years if the patient stopped to use their facilities, and if they are closing, then they have to arrange for the patient an access to his mammography records. And they inspect everything, believe me, and they select a random record, and they look at the personal qualifications and everything. The quality assurance, if any mammography facility have to develop a quality assurance program to make sure that that they are safe and consistent to provide an equal and the best mammography service to the patients. And this would compose of lead interpreting physicians, and medical physicists and quality control technologists, and they should have time to do this. And there are levels of inspections. Level 1, if the deviation is very serious, then they have to correct this within 15 days and 30 days for level 2. And level 3 will be inspected with the next inspections. The quality assurance tests, we all familiar with that, and there are tests that have to be corrected. If any problem, it has to be corrected before use of the machine, and the other tests can be, you can do it within 30 days. And all this are in the manual. You can have an access if you visit the CFR, and the test results also. اقدر اقول كلمتين بس ولا يعني انا I hate this انه اخذ شويه وقت بس معلش عشان distraction اللي حصل. So let's skip all this. Okay, so what's the positive mammogram? It's identified by the Mammography Quality Standards Act, that's by RED. The suspicious and highly suggestive malignancy are positive mammogram, and you have to notify the patient within 5 days of the results. The RED 0 is not a positive mammogram, and you have to audit. It's very important. Please audit yourself. If you don't have system to audit the entire institution, and auditing is for those. This is the minimum to audit by RED 4 and 5, and the patients. Their right is to get their report and their original images, no copies, whenever they needed it, and the institution should not cost them more than the cost of the document. Of course, the infection control and implant required to have a special training for the patient to ensure that they can practice implant protocol correctly, and the facility should solve any complaint, and if it is not solved by the facility, it should be raised to the accredited body, and again, if not raised to the FDA will decide if that is a serious, after reviewing the images, if it is a serious and patient need to be informed or not. And this is the national statistics, US national statistic. They have a 10,000 unit that was accredited, basically all the units that are accredited, and the compliance is 77% and very minimal non-compliance. Okay, and this survey is anonymous, 25 questions distributed and answered by expert European radiologists that they do 10 to 5,000 mammogram, and they have no. They all admit that they support the Mammography Quality Standards Act, but there are variations in Europe, and it's this questionnaire confirm the considerable variation in their practice, probably because of lack of funding. Our Saudi FDA, this is only 13-page document, and it is really primitive, and they describe enumerate some of their tasks without indicating the qualifications that they need or the special training that they need to have. And this is, I really appreciate this study. It's done on the Eastern Province by Dr. Halayel and Dr. Mhalna and their group. And it showed that most of our cases are presenting before age of 50, like 47%, 40 to 49, and the incidence was significantly rising. And despite absence of screening program, there was a decline in mortality. And the distribution over the referrals, distribution over the region, it's interesting to see that more than 30% are Al-Hasa referral, and followed by the Dammam and Al-Khubar. And the presentation is almost 50% regional, where the disease reached the lymph node, and distant metastasis, unfortunately, 20%. So yeah, please email me if you want to discuss, correct, or add any information. Thank you.